Welcome to the Agency for Healthcare Research and Quality's national webinar on advancing digital healthcare equity, navigating disparities in the digital age. While people are still logging in, I'm going to get us started. My name is Kevin Chaney, and it's my pleasure to serve as both a speaker and a moderator for today's webinar. I currently serve as a Senior Advisor for Dissemination and Innovation at AHRQ's Digital Healthcare Research Program, which is part of the Center for Evidence and Practice Improvement. DHR's mission is producing and disseminating evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. To fulfill this mission, the program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients, caregivers, clinicians, health systems. Today's webinar offers an exciting opportunity to explore DHR's initiatives to advance health equity, along with other federal efforts driving progress in both health and digital healthcare equity. Here's the agenda for today's webinar. Please note that we are recording the webinar and that the recording and slides will be available on the DHR website in a few weeks. You will be notified by email once they are available. We're pleased to have with us today an esteemed group of presenters, including Ms. Meagan Khau from the Centers for Medicare and Medicaid Services, or CMS, and Dr. David Hunt from the Assistant Secretary for Technology Policy, also known as ASTP, and for some of you out there also, you may remember them as being the Office of the National Coordinator for Health IT, or also known as ONC. This webinar is accredited by Affinity CE. If you're interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations, and it will also be emailed to you after this webinar. For the purposes of accreditation, let me note that AHRQ, SD Solutions, and Affinity CE have no financial interest to disclose. Ms. Khau, myself, and Dr. Hunt also have no relevant financial interests to disclose. Please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentation to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the question and answer Q&A panel located to the right of the PowerPoint slides. Please include the presenter's name or the presentation order number, first, second, or third with your question. As a reminder, participants are in listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide outlines the learning objectives for today's webinar. By the end of this presentation, you should be able to discuss CMS initiatives to improve health equity data collection and use to identify areas of disparities. Describe how AHRQ's evidence and consensus-based digital healthcare equity framework can improve outcomes while reducing disparities. And identify how artificial intelligence model creation can introduce bias and learn more about ASTP's health equity by design efforts. And now, it is my pleasure to introduce our first presenter, Ms. Meagan Khau. Meagan is the Director of the Data Analytics and Research Group at the CMS Office of Minority Health. In this role, Meagan leads the implementation of initiatives to enhance CMS's health equity data collection, analysis, and reporting of sociodemographic data, aiming to advance health equity and program development and evaluation. She also leads a team that analyzes disparities, supports research to understand their underlying causes, and works to reduce health disparities while improving access to quality care for underserved communities. Prior to joining the Office of Minority Health, Meagan was the Deputy Director of the Division of Pharmacy in the Center for Medicaid and CHIP Services, managing the operations of the Medicaid Drug Rebate Program. And now I would like to turn control over to Meagan.
Thank you so much, Kevin, for the introduction. Good afternoon, everyone. As Kevin mentioned today, I'll be speaking and highlighting some of the advancing health equity activities through data from the CMS Office of Minority Health. For those of you who are not familiar with the CMS Office of Minority Health, I just want to highlight here, or CMS in general as well. CMS is the largest provider of health insurance in the United States. And the CMS Office of Minority Health is one of the 8 offices of minority health under the Department of Health and Human Services. So what drives our data initiatives? there are plenty of opportunities for us in terms of how we should be planning out our roadmap and how to identify areas of disparity. So the first here listed are two examples of executive orders that we align our work with. The first, which I'm sure most of you are familiar with, Executive Order 13985, Advancing Racial Equity in Support for Underserved Communities through the Federal Government. And there was a follow-up Executive Order 14091 published a couple years ago as a follow-up to this first executive order. In this first one, 13985, two areas where identified method to assess equity and how we can do better with respect to race, ethnicity, religion, income, geography, gender identity, sexual orientation, and disability. The second is to establish a work group to gather the necessary data for us to be able to collect our data to get better disaggregated data, especially in the areas that I just mentioned above for race, ethnicity, gender, disability, etc. And how do we use all that data to assess equity and how well we are narrowing the gap of disparities? The second one listed there, Executive Order 14031, is advancing equity, justice, and opportunity for Asian Americans, Native Hawaiians, and Pacific Islanders. And this is one of the areas where we do have some disaggregated data. So to the extent where we can do some analysis for the targeted groups that will help us better identify areas of disparities. This is a highlight of CMS strategic plan. We have 6 pillars. The first being advanced equity. So a lot of the work we do in our office tie back to this pillar and give us a lot of motivation to how we can do better in our work. Our office also developed 2 frameworks for CMS. The first being the one to the left, the CMS Framework for Health Equity 2022 and 2032, sort of a roadmap for us 10 years out when we first released this in the fall of 2022. There are 5 priorities there, but with a focus on data, the first priority is to expand the collection, reporting, and analysis of standardized data. The second framework to the right, of course, we can't forget individuals who live in rural area, tribal, or geographically isolated communities. Therefore, we established a second framework as well. And the second priority out of the 6 priorities for that framework, again, focuses on data, increase collection and use of data, standardized data to improve healthcare in rural, tribal, and geographically isolated communities. And in addition to the 2 frameworks, we do have the different parts of CMS where we develop other framework and strategy to help advance equity across the CMS program. So the second one you're looking at is the CMS National Quality Strategy that was released this year. The mission is to achieve optimal health and well-being for individuals, right? So how can we work with the different partners across the country in order to help better deliver high quality, safe, and equitable care for all? So there are 4 priorities, as you can see here, for the strategy, and each of the priorities have 2 goals. So there are 8 goals total. The first priority being the equity and engagement with the 2 goals of equity and engagement in itself, right? So how do we embed equity across the CMS program, engage with our partners in making sure that we're advancing equity for the underserved communities, providing them the necessary care they need, but making sure that it's equitable care as well. And then there's safety and resiliency, outcomes and alignment, and then the interoperability and scientific advancement, where there's a lot of focus on how do we make sure the data we collect are appropriate in order for us to identify the different groups that are in needs and making sure that the data are interoperable. And then in the spirit of interoperability, we also have our interoperability group within CMS. Again, is to make sure that we promote the secure exchange, access, and use of EHR data to support better informed decision making and more efficient for the healthcare system here. So we look at patients and caregivers, providers, payers, and researchers and innovators, and how we can all work together to make sure that we do have the data exchange we need to have a deeper dive into the care for our patients and the needs for the caregivers. And so this next section here, I'm going to speak a little bit about demographic and social determinants of health data collection. So we do collect a lot of data at CMS, and I'm just going to highlight a few here, which will feed into what Kevin and David will speak about later. So we do try to collect race and ethnicity data collection at the disaggregated level. And this is prior to the revised OMB standards that you all may be aware of that was released earlier this year. So for our models across the agencies, we do collect race and ethnicity data at the US CDI standard as of January 1st of 2023. At that time, we also tried to align our data collections with the 2011 AHRQ data standards, which was more disaggregated than the OMB 1997 standard. So we have our data collections in 4 of our post-acute care settings, inpatients, rehab facilities, in the home health agencies, skilled nursing facility, and long-term care, to how we can better collect self-reported race and ethnicity data. And then we also collect on our Medicare Part C and D enrollment form, and a variety of surveys that CMS conduct across the programs. And here, as I mentioned earlier, OMB released this new revisions as of March 28 of this year. So they combined the 2 questions into 1 question. They add a new minimum category of Middle Eastern or North African. And then they require that the data collected to be at these detailed categories if possible. There are 2 other options, but you would have to require to request for an exemptions. And there are also updated standards in terms of definition, terminology, and guidance to the agency. So to the extent possible from now until 5 years out, which is the time frame we have to implement this revision, we do try to collect the data at this level, which will give us more disaggregated data to work from. And then we've also started a series of initiatives to collect better sexual orientation and gender identity. So the first of us collecting on the administrative form is last year, November 1st of 2023. We collected on the marketplace applications for the plan year 2024. And here's an example of what we're collecting the data for. And we're hoping that with this better data, we'll be able to identify areas of disparities, and hopefully we'll get a good sample size for us to do further data analysis. And we do collect data, but at different stages, therefore, most of the standards do not align. So one of the things that we did as part of our sort of revamping our data and expanding our data collection is we developed a resource of health equity related data definition, specification, and stratification practices. You know, it's a mouthful. What we did in this document is identify what the data definition is for each of the data elements I mentioned earlier in Executive 13985. What are the standards that we suggest, our partners, states, stakeholders who want to collect the data to align with CMS, and how would you want to stratify the data to the extent possible? And we do rely on the different existing data standards, so then we're not reinventing the wheel. And this will allow us, once we get the data at this level, it allows us to have a comprehensive analysis that can be combined or compare across the different programs, because we'll be working towards the same standard, and the resource that can be used for that internal alignment as well as for external entities to facilitate harmonizations with CMS for the data collection as well. So here's a highlight of those data elements and what we use for as standards. So the race and ethnicity, of course, we're using the revised OMB standard. For SOCHI data, we're using OMB's best practices in the NASEM report. Disability, the 2011 data standards, the same with primary language and English language proficiency. And then for rurality, we're using the CBSA, or where you want granular level data, to use the RUCA codes. And so some consideration here for those who are interested in using our resource document is this can be used by organizations and entities that wish to harmonize with CMS when it comes to data collection and stratifying and analyzing the data. Use it to the broadest applicability, and feasibility, right? And where you can use the data in the standard, please do so. But we are fully aware that not everything necessarily align with the standards. They're pretty much a work in progress, right? So as new standards come out, we will update the document and making sure that it aligns wherever possible. And to the extent where we can harmonize with US EDI data, that is our goal, right? The ultimate goal to get there. But we recognize that we are still collecting some of the data on paper form through different modes, such as telephone surveys, etc. So we have to make sure that there are appropriate data standards where we can use for different types of data collection. And then for social determinants of health, similarly, where possible, we are aligning with USCDI standards. The 4 post-acute care settings I mentioned earlier, we also collect preferred language, need for interpreter, health literacy, social isolation, and transportation. And then this data, of course, is collected through all of our CMI models. And then we also have screening measures that we put out. So both of the SDOH measure were finalized for adoption into the hospital IQR program from the fiscal year 2023 IPPS rule. So that's in our inpatient rule. And they're voluntary for 2023, but mandatory reporting starting for the calendar years of 2024. So we're looking at how we can screen better for social drivers of health and then screen that positive rate. So if you say, yes, I am screening my patients for example, specific food insecurity. So of that positive rate, what does that look like for those individuals who are screened for food insecurity? And we're hoping that this result can help us better identify some of the areas of improvements we can do in the area of SDOH. And then we also have been looking at some data analysis, looking at, for example, SDOH ICD-10 Z codes. So here is just some examples of what we've been looking at for the data in terms of the top 5 Z codes that we have done. And so the bar chart, they're looking at Z codes homelessness as the top one for our Medicare fee-for-service enrollees. And then we also did an update for our 2022 data, which homelessness went down to 3rd place compared to when we first did the data, looking at 2019 data. But this helped provide us, giving some additional data insight in terms of what it looks like for our Medicare population. And then effective this year, fiscal year 2025, October 1st, CMS finalized a rule in changing the severity designations of 7 ICD-10 codes to describe the inadequate housing and housing instability from a non-complication or comorbidity to complication or comorbidity based on a higher average resource cost for the cases of these codes. So listed here are the 10 codes that would be applied effective for this rule. And then we also put out resources for folks who are not aware of using the Z codes or how to use the Z codes. So all this information are included on our website here. So the first one is just a pathway of what are SDOH Z codes, how do you collect and document them, and how do you use the data. In the second one we released late last year is improving the collection of SDOH data with ICD-10 code. Again, is a supplement to the first infographic to provide better information in the importance of us getting the data for analysis. And then I'm going to highlight some data in analytics for health equity that we have done. So we collect all this data. What are we doing with them, right? So we have a mapping Medicare disparities tool out there on our website. It is an interactive, user-friendly map that identifies areas of disparities. You can look at the data from a county level, a state level, to the national level across the different chronic conditions, prevalence, highlighting the cause and looking at providers, availabilities, etc. And it's really, really helpful. So here's an example of another aspect of the MMD tool is looking at comparing hospital. So here's an example looking at Maryland, and these are the listed hospitals available in the state of Maryland, and looking at how do they compare across the different quality measure in terms of patient safety, cleanliness, getting the care you need, etc. So it's a very helpful tool, at least I found it to be, if you're looking for certain areas, looking at hospitals in certain areas. And then we, late last year, also added this new SDOH data sets where we utilize the data across the different agency publicly available data and created a third tab to the tool looking at SDOH across the nation. It is not tied to the Medicare enrollee. Unfortunately, we were not able to overlay the data, but it gives you an idea of, what are some of the characteristics we can look at from SDOH. So this one here, I apologize, the font is a little bit small, but looking at, individuals who are 65 and over, are they receiving preventive care? For the specific era that they are in. And again, it's a very helpful tool to look at certain areas, and we're looking to continue to add more to this data set. We also have a series of stratified reports that we've been putting out there since, I want to say 2014 or 2015. There are three main reports looking at Medicare Advantage by race, ethnicity, and sex, looking at Medicare Advantage with the dual eligibility or eligibility for low income subsidy and disability, and then looking at urban and rural disparities in healthcare, looking at using data from the CAP survey, which looks at patient experience, and then the HEDIS looking at clinical measures and see how the different measures perform across race, ethnicity, sex, rurality, disability status, dual individuals with duals, and how we could use that over time to help support and identify the areas of disparities or close the gap of disparities. So additionally, we have these data that a lot of folks want to get their hands on. And so we have a number of initiatives giving folks outside CMS opportunities to use our data. So the first here is our Tribal Data Learning Community TDLC program, which we recently launched as a pilot program. It's a one-year program where CMS fund the tribal epidemiology centers to get access to the CMS chronic condition data warehouse, or the what we call the VRDC, our virtual learning centers. And so you can get access to the Medicare, Medicaid data, and a variety of other data sets. So then they can use their analysis to identify areas of disparities or whatever is needed to determine what are the impacts based on the data we have to tribal communities. We hope that this could provide, the techs with the data resource they need, the community they need to share the information and learn from each other. We also have a Health Equity Data Access Program grant that we put out. So fiscal year 23, we put out a grant for 3 awardees. Each of the awardees will get CMS funded seats again to the CMS Chronic Condition Data Warehouse, or the Virtual Research Data Center, for 3 years to do their research based on the application they submit to us. And we hope to put out another series of grant for this fiscal year 2025. We also have the Minority Research Grant Program, which is a little bit narrower in scope, where we provide funding to support researcher at minority serving institutions. So you can see the list in the third bullet here. And again, it's giving folks some funding opportunities to do healthcare researches in area that would help provide insight into better care, access to care, quality of care for individuals in the underserved communities. And then, of course, my last couple of slides here is we're looking at how we can advance equity and making sure that everybody gets equitable care, in addition to better quality and access to care. And of course, making sure that we take into consideration individuals with disability, as well as how we can narrow that gap and help support individuals in the underserved communities. And thank you so much for your time. And with that, I will turn it back to Kevin.
Thank you, Megan. And as a reminder, we will be taking questions after all presentations, so please submit any questions you have using the Q&A panel. So we're going to move on now to our second presentation, which is what I'll be leading. And just first a little bit about me. So my journey in the federal sector began at AHRQ, actually over 15 years ago, where I supported programs and projects aimed at improving the quality and efficiency of healthcare delivery through health IT. Since rejoining AHRQ, I serve as a kind of DHR strategic advisor on emerging digital health tools, platforms, methods, helping to address critical challenges in digital healthcare and clinical informatics. I previously served as a scientific program manager and review officer for the Veterans Health Administration, and as a senior program manager for the Scientific Advancement Branch at ONC, now known as ASTP. But during my time there, I supported efforts related to the Precision Medicine Initiative, patient-centered outcomes research, as well as the leading edge acceleration projects within the health IT program at ASTP. And I also helped co-lead the development of ONC's National Health IT Priorities for Research, a policy and development agenda to support alignment between the clinical and research ecosystems. The Agency for Healthcare Research and Quality, better known as AHRQ or AHRQ, is the lead federal agency charged with improving the quality and safety of America's healthcare system. Our mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. For 35 years, the Agency for Healthcare Research and Quality has been a beacon of progress in health services research, embodying the visionary theme of today's research, tomorrow's healthcare. AHRQ has consistently acted as a research incubator, fostering innovations that lay the foundation for the future of healthcare. And AHRQ invests in evidence-generating research and translates research findings into practice. So how do we produce evidence? First, AHRQ funds health services research to understand how care is delivered and how it can be delivered better, from looking at aspects of quality, safety, equity, and value. At AHRQ, we also seek to fill the evidence to implementation gap with knowledge generation and implementation. Through the development of tools, training, resources, as well as other forms of assistance. We also provide performance measurement, data collection, analytics, and reporting, especially on quality and disparities. So when we think of, like, for instance, like what CDC is to public health systems, AHRQ is to healthcare systems. Over 20 years ago, the Institute of Medicine released several seminal reports. Crossing the Quality Chasm focused on the need to improve healthcare quality and emphasized the promise of digital healthcare technologies. And shortly thereafter, another report, Unequal Treatment, focused on healthcare disparities. Since then, healthcare technology has made significant strides. However, as the latest AHRQ report on healthcare quality and disparity shows, as well as the latest National Academy of Medicine report on ending unequal treatment, inequities stubbornly persist. AHRQ is acutely aware of inequities and implicit bias embedded in today's healthcare delivery systems and has been committed to expanding its efforts to fund and disseminate strategies to vanquish care inequities and bias and advance all Americans' well-being. To achieve these goals, AHRQ has thoroughly examined equity and its connection to agency activities in alignment with its mission. AHRQ's efforts have also been informed by the current administration's commitment to advance equity and support for underserved communities as described in this administration's executive orders, some of which you've probably heard Meagan talk about, Executive Orders 13985 and 14091. We've also done a lot of work in alignment with HHS's Health Equity Plan. So at AHRQ, our goal is to hardwire health equity into the agency's core competencies to ensure that equity is a priority in everything that the agency does to improve patient care across our core competencies. You will find a QR code here and a link to a fact sheet which provides more details on many of these activities. And as I move to the next slide, these will be eventually posted. So if you're worried that you might miss it, don't worry. AHRQ recently sponsored the publication of a health services research special issue, Achieving Healthcare Equity in the United States. Papers commissioned for this issue summarize the state of evidence and results from an inclusive participatory process to identify opportunities across areas to drive more equitable care, healthcare delivery systems and structure, payment, social determinants of health and social needs, implementation science, and access to care. The commentary, which you see here to the right of your screen along with the QR code, highlights key cross-cutting themes that can serve as a basis for informing AHRQ's health services research agenda and more broadly provides areas of collective action for the field of health services research. Algorithms have been shown to potentially perpetuate, exacerbate, and sometimes reduce racial and ethnic disparities. In the fall of 2020, AHRQ received a congressional request to review evidence on the use of race and ethnicity within healthcare algorithms, the extent of their use and impact on health disparities, and potential solutions for mitigating racial and ethnic biases to improve disparities in outcomes for racial and ethnic minorities. Some key takeaways from the evidence review at that time were when algorithms include race and ethnicity without clear rationale, they may perpetuate the incorrect notion that race is a biological construct and contributes to disparities. Some algorithms may reduce or perpetuate disparities without containing race and ethnicity as an input. Several modeling studies showed that applying algorithms out of context of original development, so illness severity scores used for crisis standards of care, as an example, could perpetuate or exacerbate disparities. Important future steps include increasing transparency in algorithm development and implementation, increasing diversity of research and leadership teams, engaging diverse patient and community groups in the development to implementation lifecycle, promoting stakeholder awareness, including patients, of potential algorithmic risk, and investing in further research to assess the real-world effect of algorithms on racial and ethnic disparities before widespread implementation. Today, the use of algorithms is expanding in many realms of healthcare, from diagnostics and treatments to payer systems and business processes. Every sector of the healthcare system is using these technologies to try to improve patient outcomes, reduce costs, but as I showed on the previous slide, evidence has shown that biases can take root, perpetuate, or even exacerbate racial and ethnic disparities. AHRQ, in collaboration with the National Institute for Minority Health and Disparities, established a panel of diverse experts representing varied stakeholder perspectives, established guiding principles across an algorithm's lifecycle to address these problems, with the overarching goals of promoting health and healthcare equity during all healthcare algorithm lifecycle phases, ensure healthcare algorithms and their use are transparent and explainable, authentically engage patients and communities during healthcare algorithm lifecycle phases, and to earn trustworthiness amongst these individuals and communities. To explicitly identify healthcare algorithmic fairness, issues, and trade-offs, and to establish accountability for equity and fairness and outcomes from healthcare algorithms. And again, there's a QR code here if you would like more information. Advanced healthcare technologies can and should play a vital role as our nation looks for systematic remedies to reduce healthcare inequities and advance the well-being of all Americans. But this can only happen if those who create and use those technologies, such as developers, vendors, healthcare systems, payers, care providers, actively take steps to make it happen. We understood that many viable solutions exist to improve healthcare delivery and outcomes. Some are designed for clinicians, some are designed for patients. Too often, however, digital healthcare technologies fail to address needs across patient populations. And in some cases, these solutions have exacerbated healthcare disparities and even created new ones. The root causes can vary, and the harm to patients and their caregivers is real. For instance, digital and social determinants of health. Patients without broadband internet may be unable to access web-based technologies. Inherent bias. Clinical decision support tools may contain biased algorithms that put marginalized populations at risk. Or poor design. Technologies that lack proper accessibility features may fail to serve patients with disabilities. Which is why AHRQ worked with the Johns Hopkins University and the National Committee for Quality Assurance to develop an evidence and consensus-based digital healthcare equity framework and a practical guide to actually help users implement the framework and bring equity intentionality across the digital healthcare lifecycle, which you will see to the right of this screen, the digital healthcare lifecycle, which includes planning, development, acquisition, implementation, and maintenance, as well as monitoring, improvement, and equity assessment. In order to develop this guide, we conducted an extensive environmental scan of the literature to understand the various types of existing models around health equity and digital health equity. And we held key informant interviews and established a very high caliber technical expert panel of over 30 representatives from federal, state, local government, academia, health systems, payers, digital health developers, patient advocates, and others who would then help shape and really inform the framework and guide. This slide is really just meant to help illustrate how our environmental scan uncovered health equity frameworks and digital health care combined frameworks, along with key informant interviews that helped lead to kind of that mapping and creation of the key domains and subdomains that would ultimately become a core component of our digital healthcare equity framework. So this graphic here represents a visual representation of our evidence and consensus-based digital healthcare equity framework. And again, which is focused on the digital healthcare lifecycle phases, which I had gone through earlier, from planning and development, the acquisition of digital health technologies, or the implementation of them, maintenance, monitoring, improvement, and assessing them. The key stakeholders of this framework includes digital healthcare developers and vendors, health systems, plans, providers, patients, caregivers. But we also have other vital groups some might not associate of or think of, but should, such as community champions, public entities like local health departments, schools, even policymakers. From the slide before, you'll see the 3 domains and each of their subdomains for how to think intentionally about equity across the various phases of the life cycle to have an impact on outcomes, which you'll see there to the right, which include clinical outcomes, process outcomes, health experience outcomes, and equitable digital healthcare outcomes. For those interested, the QR code, which you'll see on this slide, will take you to a recent blog that AHRQ published talking more in depth about both the framework and the guide, along with links to each resource. But I really want to focus on the key resource, which was the practical guide for implementing an evidence and consensus-based digital healthcare equity framework. This guide is designed to provide, again, clear step-by-step path for specific users, including digital healthcare developers and vendors, health systems, health plans, and clinical providers who want to implement the digital healthcare equity framework. And again, there's a QR code for those who are interested and would like to know more to take you directly to this resource. So getting started. Any transformational change depends on strong leadership, organizational readiness, and ongoing system support. Accordingly, this guide has 5 kind of general recommendations that organizations using the framework should adopt to start on the path toward equity, intentionality, and digital healthcare solutions. The first is to assess your organizational readiness to start down this path. And then to identify an equity champion to help bring an equity lens to ongoing efforts. Develop a diverse workforce capable of offering their lived experiences to ensure equity intentionality at an organizational level and for specific projects. Ensure that equity assessments and feedback loops are built into processes related to healthcare solutions that involve digital technologies. And then last, track equity as a part of your organizational metrics. For example, develop an equity dashboard to measure equity and intentionality in key healthcare solutions, again, that involve digital technologies across the key phases of the digital healthcare lifecycle. The guide is divided into sections based on phases of the digital healthcare lifecycle and the corresponding user groups. So, for instance, they might have digital healthcare developers and vendors looking at the planning and development phases, or health systems, health plans, clinical providers looking at the acquisition, implementation, and maintenance phases. Or the third kind of phase here, looking at the health system, health plans, clinical providers at monitoring, improvement, and equity assessment phase. And for each phase and the associated user groups, the guide offers a checklist of steps for implementing the digital healthcare equity framework. Users can click on a step to be directed to real-world examples that further illustrate aspects associated with that particular step, as well as the characteristics of the domains and subdomains, which I had shown on the graphic earlier. These things can be anything when looking at, such as, what kind of data are you collecting? What are those data elements look like? As well as different key characteristics of the populations and or the technology itself and how it was developed. The guide offers suggestions on other stakeholders to involve. Users can select other stakeholders when they go into this guide to access more information on how do you engage with them and how to do so effectively for each phase. So by following this guide, users can take deliberate actions to promote digital healthcare equity. So some kind of key takeaways. One, AHRQ is committed to efforts to fund and disseminate strategies to vanquish care inequities and bias and advance all Americans' well-being by leveraging its core competencies. Second, AHRQ's evidence and consistent-based digital healthcare equity framework, or as we could refer to as the framework, and implementation guide serves as a tool to help users and other stakeholders assess whether healthcare solutions that involve digital technologies are equitable at every phase of the digital healthcare lifecycle. AHRQ's Digital Healthcare Research Program, which this year actually is commemorating our 20th anniversary, has consistently encouraged the adoption of technologies to enhance not only healthcare quality and safety, but access to. I encourage you to visit our website at digital.arq.gov to take a deeper dive into our research program, publications, funding opportunities, tools, and webinars, such as this one, which will be posted at a later date. Here's a QR code if you'd like to stay current on some of AHRQ's latest news and events, as well as other links you might wish to follow for just general updates or comings and goings of the Agency for Healthcare Research and Quality. I have a list of references, so some of the things that I mentioned here before for those of you who might be interested in perhaps, looking back, 2 decades and seeing, rereading the Crossing the Quality Chasm or looking at unequal treatment or the latest, publication of addressing algorithmic bias and awareness. So again, QR codes as well as links for those who are interested to learn more. Here is my email address if folks have any question about my part of the presentation today or AHRQ's general activities in this area. And now, so as they say, we're kind of baseball metaphors. I know it's football season, but say we're rounding third and heading home. And so our final presentation of this webinar is going to be led by Dr. David Hunt. Dr. Hunt serves as a medical officer and the medical director for patient safety within the Office of Policy at the Assistant Secretary for Technology Policy, also known as ASTP. In this role, he provides expert guidance on improving the safety and effective use of health IT, particularly focusing on its impact on practicing clinicians. Dr. Hunt helps lead key initiatives such as the safety assurance factors for EHR resilience or SAFER guides, a widely adopted set of resources that support healthcare providers in safely using and managing electronic health records. He's also involved in the Health Equity by Design initiative, which ensures that equity considerations are integrated into health IT systems from the start. While practicing surgery, Dr. Hunt began his federal career at CMS and the Quality Improvement Group, where he designed and implemented both the Surgical Care Improved program and the Medicare Patient Safety Monitoring program. He joined ASTP in 2007 and combined his medical expertise with decades of software development experience. Dr. Hunt is deeply committed to ASTP's mission to create systematic improvements in health and care through the access, exchange, and use of data. And now I would like to turn control over to Dr. Hunt.
Kevin, thank you so much. I really appreciate your work, the work that AHRQ is doing, as well as CMS, and especially the effort to get us at ASTP to speak at this event. Before I get started, I just want to make sure you know again that I have no conflicts of interest to report. And although we've made every effort to be accurate regarding our policies and programs at ASTP, you should know that this presentation is not a legal briefing, and any questions you have may ultimately need to be answered in the relevant rules and regulations. So, with that as a clear understanding that your mileage may vary, today I really hope to review what we see as the ecosystem of health disparities. In addition, I'd like to review what we at ASTP see as the opportunities to reduce barriers to health equity using health IT. And finally, I'd love to touch on how the process of AI development can introduce or mitigate bias. For those of you who may not be completely familiar with ONC, or now as we're known ASTP, our name change and elevation within the department has not changed our overall vision or mission of better health for all Americans enabled by data. Our mission remains to create systemic improvements in health and care through the access, use, and exchange of data. And we do this by building a digital foundation, making interoperability easier, promoting information sharing, and ensuring the proper use of digital information and tools. And looking at that vision through the lens of today's discussion, I think it's important that we make clear that the pursuit of more equitable care to those for whom the lowest common denominator, that is, the least that can be done, is the best that they can hope for. This two-tiered system of allocation of health care, and I hesitate to call it a system, but this ecosystem of inequity costs us plenty. We all pay a tremendous price in lost opportunities, economic losses, and lives lost. And these losses beg a question. Do we have the fortitude, the character, and the insight to make improvements that will actually help all of us? You know, Earl Weaver was probably the best baseball manager of the 21st century. Now, I'm from Baltimore, so I'm a bit biased. But Earl yelled this question out of the dugout after a series of bad calls from the home plate. Surprisingly, he didn't get thrown out of the game for this, but it was a remarkably important question, and I love to bring this up every time I can, because we all should actually ask this. At ASTP, we actually asked this question a few years ago while examining the future of having AI embedded in our EHRs. To answer, we developed a framework that I believe applies to the question of today. Whatever we are advancing, we should integrate it to determine if it's not only fair or unbiased, but appropriate, valid, effective, and safe. We call this our FAVES framework, F-A-V-E-S. And with that framework, we've advanced a simple understanding that to be effective, elements of equity must be baked into the design from the earliest stages. We call it health equity by design. Health IT products that reinforce a foundation of equity, products that make the implicit explicit. And finally, we believe that the strategies, tactics, and patterns that are guiding principles for developers should be reinforced by the architecture and built into the system at every layer. And what are we at ASTP doing? Well, for us, everything starts with data standards. That is, we have made sure that the data set for all certified health IT, also known as the United States Core Data for Interoperability, or USCDI, includes sexual orientation and gender identity elements, as well as information such as race, ethnicity, and primary language. And beyond the data standards for health IT, ASTP awarded $73 million to train over 4,000 students from minority-serving institutions through our Public Health Informatics and Technology program, also known as the FIT program. And finally, we've started to take a look at some of the process steps of developing AI to at least have a working familiarity with its vulnerabilities and the opportunities in this domain. But before I dive into that, let me just show how we look at the ecosystem of health disparities. First, I have to give credit to the Robert Wood Johnson Foundation as the inspiration for this continuum of the connection between inequities of class, race, and gender. Here you can see why we call this the ecosystem of disparities. Interrelated nodes such as living conditions factor into risk behaviors that are often the prelude to disease, injury, and death. Our point in this slide is not to show the intersectionality of our current social order, but rather to illustrate opportunities for data to inform possible interventions. Nutritional needs for school children and young adults are wholly appropriate questions for the pediatrician's office. Zip codes with high lead markers can dictate screenings. And The entire field of modern public health as we know it was the first derivative of John Snow analyzing cases of cholera in 1854 that were uniquely clustered around a pump on Broad Street in London. We have much more data than Dr. Snow ever had, but we can't expect this to lead to better care if it's not organized, digestible, and actionable. Thinking back to my fourth slide, you'll recall that this is the practical manifestation of our mission. It is to create systemic improvements in health and care through the access, exchange, and use of data. Now, today, you can't think about the organization or analysis of large data sets without referencing artificial intelligence or AI. Now, many speak reverently in terms of AI, and they think of this as the universal solution. To those who subscribe to this liturgy, I'll say that as surely as AI will solve some of our problems, it will create others. How often has it been true that a unique contemporary problem was yesterday's unique contemporary solution? But we don't have to wait for examples of this because the derivative nature of AI creation dictates that it possesses all the vices of those virtues inherent in the system it trained under. And here we see a broad outline of AI conception, starting with the framing of the problem. What is the problem that your mountain of data can solve? And in this very first step, we can grasp a theorem that the French author Bernanos warned us about over 100 years ago when he said that the most corrupting of all lies is to misstate the problem. So clearly, our current healthcare circumstance with unequal access to care leading to underrepresentation in the data means that the miseducation of our AI starts at inception. Tacit assumptions become spurious results because the algebra of AI vector databases too often blur the line between correlation and causation. And finally, the end user fail-safe, which is our trained healthcare professionals, we carry our own baggage into this space of impressionistic art. Even if we bring no baggage, we are ill-equipped at present to recognize what is being purported as a fact without more information on how that fact came to be understood. Too few of us have the training to reliably label the output of this new AI prodigy as improper, prodigal, or lacking the nuance of compassion that the true practice of medicine dictates. And we've already seen results that should give us pause. For example, this team at Duke found that patient demographic characteristics influence the AI reading of mammograms. Now, let me explain how this review was done to understand the impact of race, ethnicity, and age and breast density on AI radiograph readings. A 3-year cohort of negative digital breast mammograms. Actually, they were tomosynthesis examinations, which simply means they were mammograms taken at many more angles than the traditional study. Well, they looked at almost 5,000 of these studies in which the patients later had 2 years of negative follow-up for each mammogram that the AI reviewed. That is, for 2 years, these patients had no diagnosis of atypia or malignancy. They were, by the best of our accounting, true negatives. Well, these true negatives were then interpreted by an AI algorithm, and you know what the algorithm found? False positives were significantly more likely in Black patients and less likely in Asian patients as compared to whites. And again, these interpretations were on mammograms for which 2 years of follow-up confirmed that they were negative. Now, if the false positives were randomly distributed, you might say, But that these erroneous readings were skewed to Black patients, well, we should say, The Nobel laureate Barbara McClintock is one of my heroes. Back before the genetic code and the structure of the DNA double helix were known, Dr. McClintock realized that genetic elements were mobile, being transposed and reintegrated into other pieces of genes. But she was a woman, a very short woman at that. And when she made her discoveries, the social structure of science dictated that significant truths were only identified by tall white men. She was dismissed. Actually, it was worse. She was completely ignored. See, tacit assumptions regarding where truth could be found meant her findings would be buried for a generation until the double helical nature of DNA and better understanding of genes made it possible to understand what was going on. Long before we knew that, she knew that genetic elements were not universally static but moved. And it's now the basis of our understanding of bacterial resistance, recombinant DNA, CRISPR technology, and DNA and gene editing. And we could all be 20 to 30 years further along in our understanding of all of this if we had just had the sense to listen to this brilliant, short woman of science. Well, what does this have to do with health equity by design and AI bias in mammogram readings? It shows us that unless we are conscious, deliberative, and explicit in our choices to give everyone the best care, that tacit assumptions built up through years of unequal care will insidiously creep into our health services delivery. Not through malice or intent, but by again ignoring the people and the places to whom and where we know our care has fallen short. Unless we are clear-eyed about our failings, we will fail again. Now, I'll end with a quote from Frank Herbert, one of my favorite science fiction authors, in a book that actually should be required reading for everyone interested in AI. It's called Destination Void. Now, in it, Herbert wrote, "Only a fool imagines he's beyond the reach of his own prejudices." And that is why we need to continue health equity by design and continue all of this work. Thank you very much. I'll turn it over to Amal now, I believe.
I'm going to step in here for Amal, but first of all, David, I just want to say thank you again, and thank you to Meagan for I hope what the audience will find was very informative, presentations with a lot of information on where to find data, tools, things that might be able to help you at your organization to better understand, all the different things that us federal partners are doing to help advance health equity, digital healthcare equity, and ultimately, as it is at AHRQ and others, is to reduce disparities in care and improve quality, safety, et cetera. So I think we got a lot of different, maybe some questions coming in to our presenters here on the question side. Again, feel free to type them into the Q&A section of the WebEx portal. And we may not be able to get to all of them today, but we will try to provide responses to all the questions in writing, and you can receive an email, kind of once these responses are available. Before I get to, kind of the kind of general Q&A here to give folks time, I want to start off with a couple of, kind of starter questions. And so first, I'm going to turn over to Meagan, and my question is, what are some common challenges organizations might face when using the health equity-related data definitions, specifications, and stratification practices technical guide, and does CMS offer support?
Yes, there will always be challenges, right? So data standardizations comes and goes, and we always try to improve our standards, right? So we can get better data to do better analysis. So as it evolves, we may be a bit behind with some of the organizations, some of the states in we are aware that some of the states don't even collect similar data on the same standards as CMS or amongst each other. So to that extent, we do have technical support. We have a health equity TA program that anytime you have any questions or want support in anything specific to health equity, you're more than welcome to reach out to us. And I will actually, I thought I may have had that in my presentation, but I will get the specific TA mailbox and put it in the chat in a minute, so everybody will have a copy of it. But feel free to reach out to myself anytime you have any question. It's just my first name dot last name at cms.hhs.gov.
Awesome, thank you. And then I'm going to skip over here to David. So David, you provided some examples in your presentation, but do you have any additional examples or scenarios where perhaps we can focus on AI that might have demonstrated bias or unfairness in framing problems or proposing solutions?
We have a number of them, fortunately and unfortunately, and the hope to all of this is that we also have examples of organizations and institutions getting it right. Those that get it right actually have a number of things that they do, and it's a systematic approach. One, they understand that in all of this work is a shared responsibility. That is to say, no one person or entity within the organization is completely responsible for everything, and we all have to take some accountability on how things are being done. Two, we have to make sure that there's training and support for all the users of these systems, not just the super users who understand the AI and can click and make prompts and understand how to navigate it very well, but all the end users that are actually involved with this. They need to understand how did this data set actually get reviewed, and what are the final outputs that it has. And finally, you have to check and make sure that what you're doing holds up. That is to say, we know that there's model drift, algorithm bias, and even hallucinations. And we have to have some metrics involved with your work so you can test it against what your system is putting out now, later, and down the road.
Yeah, I completely agree. I would say too, some of the resources, in addition to your question that people will be able to find, and some I present on my presentation was like addressing bias with algorithms, and certainly our reports out of AHRQ, they looked at, and studied, like, well, what did we find? What kinds of, instances? So we have a lot of information and data there, and again, I think, the common theme across our, presentations and also within kind of step of one another, whether you're coming to AHRQ and looking at our digital healthcare equity framework, you're looking at the equity by design, or looking at data to help better inform, or some of the frameworks that CMS have is, they're in general, they're all around a very much a central theme in how you can go about thinking about some of these things. And David, you're exactly right. It's a lot for just one person. And so organizationally, and one of the things that I've been, fortunate and working with members of our technical expert panel who helped with our framework, there are actual, C-suite level implementation folks at large centers and have been very open about, right, like when it went right and when it didn't go right and what went wrong. And we have examples in our guide of those particular type of things, and like what were the characteristics that help place everything there as a kind of a starting point. Again, because it can be, as I've heard others say, a very humbling journey.
You can't just set it loose and then say, okay, well, we're done. We don't have any responsibility. You've got to constantly monitor it, just as you would your trainees in the organization. You have to monitor this technology.
Exactly, just like our health systems, we do for other things, so around patient safety and quality, and that certainly falls within that. And one of the other questions I've seen come over across, and certainly in kind of about funding, opportunities. And so, Megan, I think some people who might be attending this might say, oh yeah, Agency for Healthcare Research and Quality, or also known as, AHRQ. We have certainly a lot of funding opportunities, which I can talk a little bit about more. But, in what ways does CMS kind of use the findings from the Minority Research Grant Program awards? And is there still currently, active funding, or may potentially be in the future?
Oh, every year we put out a NOFO, a notice of opportunity for funding. So I do see from the question there are a few students from, if you're from academic institution, definitely check it out. We put it out through our listservs. We It ranges from the amount of money we get available each year. It can be like 3 grantees, awardees, all the way to 6 or 7 awardees, and they each get a designated amount of money for 2 years to use it on whatever the research topic that they submit and got accepted for. So opportunities are always available. There's more flexibility in terms of the amount of money, but there is that list. You have to meet the requirement of the minority serving institutions versus the HEDAP grant is a little bit more broader in terms of the qualification, but you only get access funding to pay for the seats to purchase the data within CMS, but it is available annually, so definitely be on the lookout for it. And we use it there. As federal government agency, we have limitation in certain areas where we cannot do research in or that it's just not our priorities at the moment. So where these grants can come in is how you can supplement the work that we do that we are not able to do at the moment for whatever reason. So it's a nice collaboration between the academic side as well as the federal government agency. And we do highlight the work of these awardees at our health equity conference, in our quality conference. We have poster, we have them present. So we would welcome individuals to apply for these grants that they come out every year.
Perfect. I'll say too, from the AHRQ side of things, we have currently open notice of funding of opportunities available for a variety of different grant mechanisms, without maybe going too deep into the different types of mechanisms that are available and types. But we do have links, and you can find those, especially as it relates to digital healthcare research. I will also point out, and also within one of the, kind of the guides or the links that I had provided as part of mine about what AHRQ is doing is, we have a couple of what's called special emphasis notices, or SEN, which basically highlights, a priority area or an important, kind of, I'll call it, burning, issue or topic in which we encourage those applicants to focus on. And certainly we have some that are focused on looking at a whole variety of, issues around equity, health equity, whether that's at the, kind of the actual use of, equitable design, digital technologies, to hiring and training and teaching a more equitable and diverse research workforce as a part of health services research. And so we have supplements that are available, and would, again, encourage folks to go take a look at those. And again, probably same as all our, panelists here would say, oh, well, like if you have questions, we have some, emails available. We have an open email to our digital healthcare research program. I'm sure Amal puts them to the chat if you have kind of general questions about those opportunities. And we also, like CMS, on our digital.arc.gov website, things that we are funded through our program, we post all the project profiles. So if you're curious what has been funded, you can go, and we actually have a pretty robust searchable database where you can get a wide swath of what are all the different things that you're funding and focusing on here. And then I think one of another kind of question that I have for you, David, is do you think adding a human or emotional component could make an AI algorithms more useful or helpful to the patient population?
That's a great question. To be honest, I don't know. It may be that that's a helpful way to go. I think that institutionally and broad groups of institutions have to test and find out. The most important thing that I think that should be done is, again, that the AI is monitored, the outputs are monitored, and you can test systems that, one, have human prompt or a human that is at some point in the chain before the final output, and those that don't. You have to check and see. I think it might be a little bit early for me to make a proclamation that yes, you need it, and it really depends on the individual use for it. That is to say, in some instances, you have AI. We have AI in the examination suite, taking our working side by side with us to take the patient's history, so I don't have to type it down. So with that, I can intervene and I can look and review almost immediately in real time. Oh, yes, that's exactly what was said. Whereas in other systems where you're determining, wow, which antibiotic should I use? We may have to have some at least oversight to say, oh, where have the infectious disease specialists periodically look and say, you know, those antibiotic recommendations, they don't really fit our guidelines right now, and we might be having a little bit of AI drift. It's hard to say exactly how we should do this. I would say it's an all-hands-on-deck moment where we all take the time and effort to monitor these systems.
Yeah, completely agree. One of the things here, I think, kind of to kind of wrap up, kind of my questions, and then we'll dive in and see what kind of Q&A we have from the, audiences. One of the things that I've been asked about, for instance, our digital healthcare equity framework and guide is, people say, well, what kind of solutions, right? Like, is this guide supposed to help me with? And, I let them know it's actually a guide that can help you from a very simple type of solution. So for instance, just like, oh, we want to create a patient dashboard or electronic sign up, to more complex things. So like David is talking about, AI algorithm development, decision, cognitive support, even looking at system level things like risk prediction, perhaps sepsis prediction, which we found, those models had challenges and had been reported on. And also, fortunately, those researchers who had been, funded to look at those things, are coming together. I think, say as a broad community. Again, David, Meagan, and others said, it takes a village to do a lot of this work and input. And again, so kind of going back to like, I'd say that our guide is, well, like, do you have like some examples? And I do, from like the very simple again to the complex. So like for instance, one of the things that we highlight in the guide is like, it was actually a very well-intentioned example, and it was during the COVID-19 pandemic, right? Systems and pharmacies were creating online digital signups, as the access entry point. And that makes sense, right? We were social distancing and trying to figure out, do this, very, very rapidly. But at the same time, there was a tension because some of our most vulnerable, who maybe were at the most need to be able to receive, either care or vaccinations, weren't able to sign up. And this is not to say that a digital sign up should not have been used, but through the guide, it could help developers and implementers consider how various populations would be impacted, right? To ensure maybe alternative solutions were created, for those populations and to have input. Another, kind of, example that I've heard from, systems is, whether or not, and very deliberate over the use of whether or not when they provide maybe mobile health tools or digital tools to their patient populations, are they Bluetooth functionality or are they cellular enabled apps and devices? And generally, cellular is more equitable, right? But those are some, things or decisions like some people may not think. And again, it's kind of, kind of things like this that the guide, is meant to help kind of pace people through. And same thing with the, equity by design is to have those kind of intentional kind of thoughts. I'm like, how does this, have an impact? And again, even though to the more complex solutions, so whether you're developing algorithms or multifaceted algorithms, it provides this roadmap of kind of, like who should be involved. Again, considerations to think through, inputs, parameters. How was the model trained? I saw some questions in this, right? And David and others had alluded to this is like, well, what kind of data? Where did that data come from? What do we know about that? And so, again, just really really important things, especially how it might perform. The model might have been trained and tested in one setting. How is it though going to perform in a new setting? But also for those on the call, right? Like these are opportunities to hopefully work with the vendor, right? Who might be providing, whether, if you're not doing it, developing it in-house, or if you're working with a, a vendor. And so kind of my last closing thought, I'll say this, but kind of the digital health equity framework. And that is, what I hope will be, communicating though, again, is just a common reflection from, whether it was many members of our technical expert panel who helped provide insights to the guide just to the day-to-day operationalization, and thinking that it takes time, and as I said, and having important data insights like from CMS to maybe better target and understand like where there might be a challenge or an area also means that there's opportunities there to innovate, and to again come and up to that point and challenge, even though right this is and can be certainly a very uh, humbling journey. With that said, I'm going to try to see here if I can go to some of our Q&A questions. I have let the Amal, who's helping us kind of back end, I have lost the ability to unfortunately answer some questions. I was doing that earlier. But I'm going to kind of go through here and just see if we had any particular questions. It looks like we've replied to a lot. Yes, slides, the webinar, and everything will be posted and made available. Let's see. I try to answer this question. This comes up a lot. We do have a lot, right? Like digital health startups and others who are interested, say, how do I get involved or can I apply for AHRQ funding? And as usual, right? Like sometimes the devil's in the details on what kind of eligible organizations that we allow in our notice of funding opportunities. And that can probably be said across both ASTP, whether they're doing their leading edge acceleration projects and Health IT, or to CMS, is what kind of eligible entities are available, and that can vary depending on the type of mechanism or what we're looking at. And certainly, what I tell typically a lot of digital healthcare vendors is they themselves, maybe as a private or profit organization, may not be able to directly apply to all of our type of eligible funding, but we do see a lot of people partner. So that's when we usually see a lot of these digital health startups typically do partner. Maybe perhaps it's with like a larger health system or an academic medical research center. And those can be certainly pathways for those who are looking to try to see and learn and different things. And then I think I saw in here somewhere, David, it looks like we might have a question about the SAFER guides.
Yes,
It
yes.
says,
I want to thank Jetty Edelman for asking about the SAFER guides. For some of you who may not know, the SAFER guides are a set of 9 self-assessment guides that end users, organizations, small practices can use to evaluate or assess how well they're using their health IT. Currently, we just finished an update of the guides, and they're going to be released in January of 2025. They've been slimmed down, modified, and refreshed in terms of the references as well as some of the recommendations, including a very excellent recommendation around AI that really echoes a lot of what we've already heard here. That is to say, it takes a village. That is not something that can just be set upon, wind up and then just let it go fresh. But keep an eye out. We're going to let everyone know about how you'll be able to access those new and improved SAFER guides in January 2025.
perfect. Yeah, that's great. And I think for me, and again, as I mentioned before, is one of the key, areas, and sometimes this takes work, but a lot of some of that pre-work that went into the SAFER guides, distributed funding and resources by fellow agencies, AHRQ, ONC, that had helped it, well over probably a decade ago, but continue to have served as a really important foundation. I think it speaks to the impact, right? Like research funding, and sometimes it can be a hard challenge or question. People say, well, you funded this, what might be my, kind of return on investment be? And, I would say this is one of those key, examples that it can take time, but what comes out of it and, these guides that can be more broadly utilized, across, and also too, we will continue to fund research and say, like you had mentioned, like, well, take that and evaluate it. Maybe your system, what differences might there be? And help us understand so that we can inform and, make the necessary changes to guides so that way they're the most helpful and beneficial to help health systems, whether you're looking at EHR, integration and how that is implemented at your system to updating, to also looking at, you know, issues around, equity, and certainly around, algorithms. I saw a question, on here earlier too. Someone had mentioned, like, well, what about, the raw data? And I would just say, and I think David mentioned this, and CMS, and that's why, efforts by CMS and ONC to try and get, part of this is it's a quality of data issue. And it can certainly, it's reflective, right? We have data, they have biases baked into them, but being aware of those, and then what do we do moving forward to help try to, mitigate and create higher quality data to be utilized, whether for, algorithm development, but also just for better, awareness. And so people, clinicians have a better understanding, right, of how maybe models were trained. And, I think there's a lot of collective action, both across government, industry, and others, because, it's important to have high quality data. Megan, I don't know if, you would like to perhaps, and then maybe David, talk about some of, right, like the impetus, right? You mentioned a little bit in your presentation of, CMS is, kind of striving to help provide higher level quality data that helps you, right, from all different aspects.
Yeah, but I think David has a comment, so I'll let David go first.
Yeah, I just wanted to say we found years ago one pro tip in collecting data on race, ethnicity, and social determinants of health, either at the practice level at the ambulatory clinics or offices, or even at the hospital organization level, is to give the patient or their surrogate the opportunity to answer the question by themselves. Okay, without you necessarily asking. In some instances, it will be obvious. Someone will ask, well, are you black? And you say, yes. We get cleaner, better data when the patients or those involved get an opportunity to answer it, often in private. And so in some instances, that means that there's a little data input kiosk in the waiting area where, as you come in for your appointment, you're assigned a small tablet and a screen is available so you can put in that information. When our patients are allowed to input that data, you get better, cleaner data in general.
And I agree with David, right? The gold standard is self-reported data wherever possible. And that are some, there are some challenges we have with that. So, for example, in aligning with the US CDI standards, we do our utmost to do that, but we are looking for the Medicare program individuals that are 65 and older. So we're still using paper-based form, or you come to the SHIP centers and they help you fill out. Or telephone surveys. We simply can't read through 900 plus categories of race, right? So we have to look at, to your earlier question, Kevin, we have to look at the minimal standards, like where we can feel like we have enough time to get the information back, because that information is very important to us. And we are also aware that sometimes, it's not the data doesn't impact your eligibility status, whatever, and it is optional. And so people just gloss over, oh, you don't need this information. Let's get to the important questions. So as a result, we don't get good data. But in us continue to strive to get better data, we do put in some measure in the meantime as we continue to weigh out getting better data is we develop an imputed algorithm, right? The Medicare, we call the Medicare imputed algorithm for race and ethnicity, where we get the data from SSA, from the census, from H.S, and we put them together and use our best methodology in hoping that when we get self-reported data, we can sort of do a mix of both, which is what our Medicare imputed Medicaid side of the house does, where they have self-reported data and they validate it. They use that self-reported data, but where the quality of the data is unsure, unknown, and we do get proxy data, right? So there's the part where the family member gives the data, or the provider simply look at you and say, I think you're this, check the box. And we may get like same person, 2-3 different data points. So then at that stage, we'll use imputed algorithms to make the best of both worlds. But we do hope that as we continue with this data collection and with the new OMB standards, that we'll be able to get better data, but disaggregated data, so we can do more target intervention instead of just, generalizing that all Black individuals are the same, all Asians are the same, when technically we're not if you break it down into the subgroups.
Yeah, and I too, we were talking about, kind of, patient provided or, patient reported, information. And certainly I would say too, AHRQ has done a lot of work to help support, through PCOR or patient-centered outcomes research, institute, and a lot of the research and funding. And I'll put a plug in for, AHRQ's efforts around clinical decision support or CDS, and especially looking at, right, clinical decision support. I think if most people have heard that term or whoever think, oh, well, it's all provider facing. And we're moving in, especially with new digital health technologies and everything, and shared decision making is patient-centered clinical decision support, and really looking, though, at aspects that help drive that, which is patient-reported outcomes, patient input that's given as a part of that data that can further help ensure that, whatever the health system is, or your provider, whatever, right, has the best information at the tips of their fingers, so that way they can make, right, probably the most best and informed decisions with their patients. And so again, it goes back to, an important aspect, and how do we try to collect that data without being, too much burden, whether that be to patients, family members, caregivers, or providers. And how can we do that in a thoughtful way across our technology? So if you are curious about that from AHRQ, you can go to cds.ahrq.gov, and you can get a whole smorgasbord of all the different things that, our group over there has been, working to help advance things from a patient-centered perspective. It's 4:27. I think there's a couple more questions here. We will, like I said, work to have those answers provided, so that way people will have a response if we didn't get to your question. I appreciate, folks' patience, and thank you for everyone who attended, and for those interested in obtaining continuing education credit for participating in this webinar, please visit the URL shown on the slide here. And you have 14 days to claim your continuing education credits. And so upon exiting today's webinar, AHRQ is also fielding a brief evaluation. We hope that you will complete the survey to share your feedback with us. It's helpful and important for how do we make these hopefully as valuable and informative to our folks that like to tune in. And with that, thanks again, Megan. Thank you, David. And thanks, folks, for tuning in to today's webinar. Really appreciate it.